Hi, my name is Tony Tsai. I'm an anesthesiologist at Mount Sinai Beth Israel in New York. And I did my residency and fellowship at St. Luke's Roosevelt Hospital Center. And the fellowship in regional anesthesia was done with Admir Hadzik at Nice-Sora. And my interest is really in regional anesthesia and preventing complications from nerve blocks. So today I'm here to talk to you about minimizing risk with supraclavicular blocks. So this is where I work. This is a shot of Beth Israel. It's located in downtown Manhattan, and it is now part of the Mount Sinai Health System. So our goals today are really to go over an overview of the brachial plexus anatomy, review how to perform the supraclavicular blocks with nerve stimulation and also with ultrasound, go over some of the complications that you can get with the supraclavicular blocks. And finally, I want to go into pneumothorax and phrenic nerve blocks and how do you minimize the risk of each with the ultrasound approach. So this is our brachial plexus. As you can see, the plexus arises from C5 to T1, and when we're doing the supraclavicular block, we're really looking at the divisions. We're blocking at that point. So as you can see, the ulnar is always an issue. It may be spared, and so I'll go into a little bit on how to prevent that from happening. With our nerve stimulator technique, we are going to need certain equipment. So the first thing you're going to need is the nerve stimulating needle. I use a 22 gauge 50 millimeter needle. Everyone has their own preference for choice of local anesthetic. And usually I draw out 5 cc's of lidocaine for local skin infiltration. We always need a nerve stimulator with an EKG sticker, a marking pen, betadine prep solution, and sterile gloves. The landmarks that I use to look at are the lateral border of the clavicular head of the sternocleidomastoid, and I usually measure a point 2.5 centimeters lateral to this, and that's going to be the entry point of the needle. So the block needle is going to be angled lateral and posterior to the clavicle at this entry point. This is a picture of where the entry point would be for a supraclavicular block. And when we insert the needle, first we anesthetize the skin with our lidocaine, and the block needle will be inserted in a lateral and posterior orientation to the clavicle. As you're advancing the needle, first you look for a stimulation of the shoulder, and once you find that, you want to angle the needle in a caudal and posterior direction. What I'm looking for is stimulation of the muscles in the hand at a current of 0.5 milliamps. And this is an example of how you would place the block needle and the direction that you would initially use in order to find the stimulation of the shoulder, and again, redirect caudal and posterolateral once you get that stimulation. So the second part of this is to review the ultrasound clavicular block and what landmarks and how you would approach that. So the equipment is the same, except you need a ultrasound machine, and usually our machine has a 12 to 15 megahertz probe. I use a probe cover, and you also need some ultrasound gel. So the probe is placed parallel to the clavicle, and the inexperienced practitioner should really start medially so that they can locate the carotid artery. Once they find the carotid, they can scan above the clavicle and move laterally until they locate the subclavian artery. The first rib is going to be hyperechoic or white, and it will be just inferior to the artery. And you will also see the hypoechoic region, which is the pleura, and that's underneath the first rib. So the round hypoechoic divisions and trunks of the brachial plexus are visualized lateral and inferior to the subclavian artery. This is an example of how you would place the probe on a patient. And again, you would anesthetize the skin with local anesthetic and insert the block needle in the lateral aspect of the long axis of the ultrasound probe. So you should place the subclavian artery on the medial side of the screen, and the block needle will be seen as it's being advanced from the lateral aspect of the probe. Oftentimes there's a fascial sheath that is lateral to the brachial plexus, and this needs to be traversed in order to have a successful supraclavicular block. So this is how you would insert the needle. As you can see, it's along the long axis of the probe. This is just an ultrasound picture of the subclavian artery, which is in red, the lung, which is dark, and the orange line is the orange lines show where the brachial plexus is. Our white needle is located with the blue triangles, and finally the first rib is located with the green triangles. And this is a orientation of the same thing with the local anesthetic, which is now highlighted in pink. So what complications can occur? Well, pneumothorax is one that everyone worries about, as is phrenic nerve block, intravascular injection, hematoma formation, and nerve injury. But today I'm going to concentrate on talking about pneumothorax and the phrenic nerve block and how to decrease the risks of both. With pneumothorax, Brown and Bridenbaugh in the neuroblockade book estimated the incidence to be 0.5 to 6% with the nerve stimulator approach. And Barrington and Abel in RAPM in 2014, they estimated that the ultrasound approach decreased that incidence to about 0.4%. Mostly the tips that are given to decrease pneumothorax are to always keep the needle in view, and especially the tip, and to use hydrodissection or hydrolocation as necessary to locate the needle tip. You can use a solution of either the local, or you can use a solution with mixed with saline. Third, you should always know where the first rib is and stay superficial to the rib. Those are the three most important things that you can do to decrease the risk of pneumothorax. So what about the phrenic nerve? Well, the phrenic nerve originates from the C4 nerve root, and it has contributions from both the C3 and C5 roots, so it's in the cervical plexus. It usually travels along the surface of the anterior scalene muscle, and it enters the thorax between the subclavian artery and vein. Although there is an accessory nerve, phrenic nerve, that can originate from C5 and C6, and this is present in up to 75% of cadavers. So the incidence of phrenic nerve block with nerve stimulator or paresthesia technique ranges from 50 to 67%, as Neal et al. Found. But Rennes in 2009 compared a nerve stimulator and an ultrasound technique for supraclavicular block, and used 20 cc's of 0.75% ropivacaine in 60 patients. In the ultrasound group, they found 0% of phrenic nerve block, and they deposited the local caudal and posterolateral to the brachial plexus. And in the nerve stimulator group, they found a 53% incidence of phrenic nerve block. However, this study was not powered to detect the true incidence of avoiding the paralysis of the diaphragm with a supraclavicular block under ultrasound guidance. But because there's anatomic variation in the phrenic nerve, it's possible that less local anesthetic can result in a partial phrenic block, which would preserve your FVC. If you're using the ultrasound approach and you're only placing the local anesthetic in the corner pocket, as some people have described, which is the inferolateral or lateral aspect of the subclavian artery, you can avoid a phrenic nerve block, but you can also spare the ulnar distribution of the brachial plexus and not get a complete block. So that's something to worry about when you're doing the corner pocket technique. So tips to decrease the risk of phrenic nerve block with the ultrasound approach are to deposit the local caudal and posterolateral to the brachial plexus, and also minimize the amount of local anesthetic needed for the block. So, in conclusion, The supraclavicular block is a very useful technique to block the brachial plexus, but has known complications. Our nerve stimulation has an incidence of pneumothorax between 0.5 to 6% and incidence of phrenic nerve block between 50 and 67%. With the ultrasound technique, the incidence of pneumothorax has been shown to be 0 to 0.4%, and phrenic nerve block can approach 0%. So the tips, again, to decrease the risk of pneumothorax with the ultrasound approach are to keep the needle in view, especially the tip, use hydrodissection or hydrolocation to locate the needle tip if you can't see it, and also to know where the first rib is and stay superficial to that rib. Tips to decrease the risk of phrenic nerve block and with the ultrasound approach are to deposit the local anesthetic caudal and posterolateral to the brachial plexus, and to minimize the amount of local anesthetic needed for the block. In order to completely prevent phrenic nerve block, if you're worried about a patient's respiratory status, you would then use either an infraclavicular or an axillary approach to the brachial plexus block, meaning something distal. Thank you for spending time and listening to our lecture on how to minimize the risks of supraclavicular block.